Good morning, everyone, and welcome to our 2022 AFib Symposium, a multidisciplinary approach. This symposium is sponsored by UPMC Heart and Vascular Institute, as well as the Heart Rhythm Society. My name is Samir Saba. I'm the co-director of the Heart and Vascular Institute and Division Chief of Cardiology. And my co-chairs for today are Dr. Sandeep Jain, who leads the EP group at UPMC and is the director of its AFib Center for Excellence, as well as Dr. Mark Estes, who's the program director for the EP training. When we set out to put this program together, we had two main goals. The first goal was that, true to the title of this symposium, we wanted it to be multidisciplinary. And hopefully you will see with the faculty that we have on board today and the speakers that we are really doing a multidisciplinary approach to atrial fibrillation. Atrial fibrillation is the most common arrhythmia. It is touched by so many different physicians. We have the usual suspects, the electrophysiologists, but we also have the cardiologists who practice in tertiary centers as well as in community centers. We have heart failure physicians. We have CT surgeons, and all of those individuals help in the treatment of atrial fibrillation. The second goal that we have for this symposium is to reach and bring value to as broad a spectrum of individuals as possible. So hopefully, if you're the cardiologist or the electrophysiologist who is interested in knowing what's happening in the world of electrophysiology, in the world of atrial fibrillation, the newest technologies for AFib ablation and for left atrial appendage closure and clinical trials, you'll find value here. But if you're also a trainee or an APP or a registered nurse who wants to fresh up on what's happening in AFib, you will also find value, as well as if you're the primary care physician or a family practitioner who wants to know the new things that are happening and when to refer your patients for the electrophysiology expert opinion, you will also find value in all of the above. Our session today, our symposium today, is brought up in 3 sessions. We're going to have a break between the first and the second 2 sessions, which is a brief break. We're going to have a moderation of each one of those sessions. We want it to be very interactive. So if you are here at the Haberman Conference Center at UPMC, please, after the presentation, step up to the microphone and ask your question. If you are on the line, the moderators, myself and Dr. Jan and Dr. Estes will be monitoring the chat box, and we will answer the questions for you. A couple of housekeeping recommendations. Please, the ones that are here in the conference, silence your beepers and pagers. For the speakers, please stay on time so that we don't cheat our audience from the ability to interact with us and ask questions and do what they need to do in terms of getting the value that they are looking for. And a reminder that I will do today, this morning and later, is that there are CME credits associated with this symposium, 3.75 equivalent hours maximum that you can claim. So please, claim whatever you've attended, and we'll remind you of that at the tail end. Before I forget, a big shout out to Angie Kanunen, who was the powerhouse behind this whole operation. She put it together, and with the physicians, with my co-directors, we were able to put it in record time, and the attendance has been great. All right, before we start with our first session that I will be moderating, I'm going to ask you, James, if you could pull out the poll to see what is the breakdown of our attendance. So please vote. I think the folks in the room cannot log in and vote unless you have your own computers, but we'll wait a little bit to see how many we have and what's the breakdown. James, can you tell what's the percentage of folks that have already voted? Oh, it's up there. Okay, 73. All right, nice breakdown. So we have a number of APPs and nurses. We have trainees, a smaller number of electrophysiologists, but that's not too surprising. We are a smaller number of individuals compared to others. A nice breakdown all over. So we'll drive the discussions in those directions. We would like contribution and questions from all the different subgroups of that are attending, and we will start with the first session. Okay, the first speaker for our session is Dr. Aditya Bhonsale. Aditya is a assistant professor in electrophysiology at the University of Pittsburgh Medical Center. His research and clinical interests have been in inherited arrhythmias, and he does a lot of research also in atrial fibrillation and the predictors of atrial fibrillation. And his title of his presentation is Screening of Atrial Fibrillation, What the Cardiologist Needs to Know. We used to just get EKGs or feel pulses or stumble on atrial fibrillation. Now in the world of wearables and Apple Watches, the lay of the land is changing. So Aditya, the stage is yours.
Thanks, Amir. I'm delighted to be here. I'm Aditya Bhonsale. I'm one of the cardiac electrophysiologists. And I was asked to talk about this, which I thought was really interesting because it really is expansive, but at the same time touches electrophysiologists, cardiologists, and especially internal medicine people as well. So I have no disclosures. Relevant financial relationships are none. And the primary question is why screen for atrial fibrillation? And for people with undiagnosed atrial fibrillation, ischemic stroke may be the first clinical manifestations. In fact, 10% of people who present with a stroke are thought to have atrial fibrillation diagnosed around the time of these events. And when used appropriately, it's been shown that oral anticoagulation is estimated to reduce the stroke risk by almost 65% compared to doing nothing. And the idea and the premise is that if it was possible to detect those that had asymptomatic atrial fibrillation earlier, it may be possible to prevent some of these strokes by offering anticoagulation. And we'll come to some of the nuanced situations where that's not so clear of an answer. Also, the big idea is that there are people who are undiagnosed with atrial fibrillation. And the estimates from various studies suggest that 15% of patients with atrial fibrillation are currently undiagnosed, and of whom up to 75% may be eligible for anticoagulation. So therefore, screening is suggested as one strategy to increase AF detection rates and start anticoagulation early in high-risk individuals. And the paradigm that Samir was referring to is that there are different kinds of screening. One is called opportunistic screening. And this is something we do every day or should be doing every day in the office, where we check for pulse, auscultate the patient, and diagnose atrial fibrillation. And those are brief episodes, and therefore the AF yield of doing such a thing is, in most studies, has been about 1 to 2%. And then there is this bigger, more controversial idea of systematic screening, as in take patients over 65 years of age and screen everybody for atrial fibrillation, either through a single snapshot, which is that clinic visit, or through now, multiple snapshots using home monitors or some kind of wearable devices, or even continuous recording with loop monitors. And as you can see, there's this emphasis and technology that's available now for consumer-driven, where anybody at any point of any age can look and find out if they have atrial fibrillation or not. And there's a balance of how much yield there is. And as you look more, there is more atrial fibrillation to be found. But the drive home message, one of the ones that I want to give today, is that doesn't mean the stroke risk is higher in those that have more monitoring. And we'll come to some of the data for that. So that's definitely a balance between AF yields and stroke risk and trade-off as well. The first question to answer is, does screening for atrial fibrillation, with any test that you may identify as older people, detect more effectively atrial fibrillation than usual care? And this slide has a lot of information. I don't want you to focus on that, but just understand there have been a number of studies over the last decade that have looked into this. And many of them suggest that screening can identify more patients with atrial fibrillation. And you could use any number of strategies. And all of these studies have varied from patch monitors to a live cord to longer monitoring, but all of them suggest the same idea. And most of these studies were done in Europe, actually. There's very few studies done in North America. that contribute to it, except the one published day ago in Circulation, where this is 16 primary care clinics in the Boston region, looking at 15,000 patients seen in primary care offices, where they did a live core on each one of those patients, randomized to one, and the other ones was just usual care, showing that they could diagnose about 1.72% of individuals, which is kind of par, but made no difference as compared to usual care, suggesting that the optimal strategy, even among opportunistic screening, is unclear for these patients. Some of these tests have variable accuracy, but again, the graph is not meant to scare, but the table shows that most of these devices, or home blood pressure monitors like the Omron M6, have reasonable sensitivity and specificity, over 90% at diagnosing atrial fibrillation. But the key highlight here is all of these false positives, right? So these are numbers assuming a 1.5 or so prevalence of atrial fibrillation. So for almost every 1,000 tests done, you could falsely diagnose atrial fibrillation anywhere between 30 to 250 patients. And that has implications. And we'll talk about some of the downsides of screening as well. And therefore, it's very important to understand that the positive predictive value of any screening test is actually going to be contingent on the AF prevalence in the population that you study. So it's not only the modality, but the population that you're trying to understand the AFib from. And there's a whole host of monitoring devices. They could be intermittent, like the Apple Watch. They could be continuous, like having an implantable pacemaker. They could be minimally invasive, that you really don't, you don't know you're being monitored. Or they could be a constant reminder every day when you turn to your left side. So there is a wide variety of things that we have in our armamentarium. And I'm going to go over a few of them just to give you a feel of what this situation is. So the most common, made famous by the Apple Heart study about 4 years ago, is the Apple Watch, which uses photoplethysmography. And it basically means that you're creating a tachogram using intermittent blood flow monitoring, using an algorithm and AI basing as well to detect atrial fibrillation. And it works pretty well. It works in studies at 70 to 85%. Positive predictive value. And then when you combine the camera portion of the watch, you can even make it even higher. So that's one. Even the Zio patch, which is something, again, I'm using trade names, but any kind of 2-week monitor that you use has been studied to show an effectively comparable to Holter or even devices. The correlation is like 0.9 for using a Zio patch for monitoring atrial fibrillation. And again, there are other things like on Amazon, you could order today the Cardia Mobile, and if you're a Prime member, get it delivered by Wednesday for $79.99. So those are all things that are there in the patient's hands. And Cardia has actually been studied in more than 1,000 patients, showing over 95% sensitivity and 91% specificity for AF detection. And those are all things that are there out. But there are other traditional things as well. For example, a simple blood pressure monitor, which is the Watch BP study, which can give you a notification whether or not you have an irregular pulse and it's suggestive of AFib, did very well in studies. And then some things that we use commonly, the BioTel e-patch, the MCOT, we get reports every day, have been the most extensively studied monitoring systems with nearly 100% sensitivity and specificity for detection of atrial fibrillation, and with or without telemetry based on how you use. So all of these are out there as potential strategies of monitoring. The two ones that are more invasive are these loop monitors, as well as implantable devices, and which kind of leads into the bigger question of what do you do if you detect atrial fibrillation on a device? And there's been multiple studies in the past, and this is a whole list of studies looking at patients who had ICDs or pacemakers put in for some other reason, and nearly 30 to 50% of them over a 3-year follow-up were noted to have atrial high rate episodes, surrogates for atrial fibrillation. But the key point here is this, that many of these studies showed no difference in ischemic stroke or systemic embolism between those with or without atrial fibrillation. So just detecting more did not necessarily mean that they did better. So I think that's one of the things that's very important to understand as we kind of learn more about AF screening in the future. And therefore, the concept of burden of atrial fibrillation or burden of subclinical atrial fibrillation is very important. And one of these studies, basically, and if I go back to the study that this is referring to, is the ASSERT study. The ASSERT-2 showed that as you follow patients with devices, there's an increasing burden of atrial fibrillation that you can detect, which is shown by this graph, years of follow-up and cumulative incidences being the two axes. But a lot of atrial fibrillation that you see on those devices is brief duration. So you can see the 6-minute episodes really go up as compared to the 24-hour episodes that don't increase that much. So that's one point. And the other point is that the outcomes may also be contingent or tightly related to the amount of atrial fibrillation you're having, not necessarily yes or no. And again, from ASSERT, we know that, and this is part of why the guidelines are the way they are, that over 24 hours of atrial fibrillation was associated with significantly increased event rates of ischemic strokes, whereas the others weren't. At the same time, there seems to be more nuanced information from these studies. One of them being on some pooled analysis that it matters what your initial episode is. So there's these bar graphs basically show incidence of atrial fibrillation greater than 24 hours, categorized by what the duration of the initial episode was, suggesting that longer initial episodes are more likely to predict an episode over 24 hours in a kind of an incremental fashion. So it's very important to look at the duration of your episodes. And therefore, there's a linear regression that can be fitted on to the log AF burden that suggests that there is an increasing adjusted hazard ratio as the burden of atrial fibrillation increases based on all these cumulative studies that have been done in the past. And therefore, this is one of the slides that is kind of a take-home slide where the decision-making with device-detected atrial fibrillation has to integrate both the duration of atrial fibrillation as well as the clinical picture, which is the clinical risk of these patients. And there are some groups or some boxes that we know very clearly what the answer is. So A, you have low risk, you have really very brief infrequent AFib, do nothing. C, very high risk patients having persistent greater than 24-hour atrial fibrillation. Obviously, somebody that anticoagulation should be considered if the risks are not prohibitive. But there are many other groups here, say, for example, somebody with a CHA2DS2-VASc of 3 who has a 6-hour episodes, right? So they are really in the middle here. And we'll talk about some of the trials that are coming to investigate this population, but it is a struggle in us trying and everybody trying to stratify these patients in terms of their risk. But I would encourage everybody to keep these things in mind, that it's not just the duration, and it's always the clinical scenario that has to be integrated with these patients, because there are risks of screening, because it's not a slam dunk. Population level screening could lead to a considerable number of false positive results that would hamper our ability to deal with the patients who actually need to be dealt with. There could be downstream side effects of getting an echocardiogram in anybody who got atrial fibrillation, or even in more invasive monitoring or other monitorings. There's significant health anxiety, and we deal with this every day as to what the implications of their diagnosis are when they are asymptomatic and haven't really known that they have atrial fibrillation. And then for certain subgroups, there's always this risk of, does a 5-minute episode of atrial fibrillation in a 90-year-old who has fallen twice in the last 6 months is worthwhile? And therefore, there's increasing bleeding risk in starting anticoagulation in some of these frail patients. In order to answer some of these questions, interestingly, over the last 1 year, there have been 3 major issues or studies that have come out. And I'm just going to briefly touch on them just to see how they have been integrated. One of them is the Safe Stroke study. The other one is the Loop study. And based on these two, there are some recommendations made by the US Preventive Services Task Force that came out a few weeks ago. The Safe Stroke was the first large randomized controlled trial of systematic ECG screening. And a lot of people, more than 20,000 in a European country, were randomized to get screening or to just have follow-up. And nearly 50% of those invited did participate in this with a thumb ECG twice daily for 14 days. And a lot of patients got anticoagulation in those that were diagnosed with atrial fibrillation. And the study found that you could reduce, and again, this number is important, 1.1% absolute risk reduction in favor of the screening intervention group, a smaller benefit than initially anticipated, and actually no reduction in ischemic stroke. So actually a positive result, but placed into clinical context, a very small effect size. The other one is the Loop study, again published within the last 1 year, that took about 6,000 patients, older, randomized them in a 1-to-3 fashion to getting an implantable monitor versus usual care, and saying that if you have greater than 6 minutes of atrial fibrillation, we're going to call it, and diagnose 31% of patients with atrial fibrillation as compared to 12% in the control arm, and started anticoagulation in quite a bit, but did not show any difference in any of those outcomes in terms of overall mortality, stroke, or other cardiovascular outcomes. Suggesting, and I think this is one of the important take-home messages, that not all screen-detected atrial fibrillation should or merit anticoagulation. And I think as we understand this field better, we will hopefully be nuanced enough to detect which ones should and should not. But this is a strong paradigm, I think, that's going to be supported by guidelines in the future. And finally, coming to guidelines, what do the current guidelines say about atrial fibrillation? And and I'll tell you the tension between some of these guidelines. And the ESC in their 2020 document kind of reiterated what their position for Europe is that we want patients over 65 years of age to have opportunistic pulse, AF detection, either with a pulse or some ECG rhythm strip. And in fact, consider even in older patients getting an ECG. So those at higher risk for strokes. And that's a class 2 indication. But stronger than maybe the American Heart Association statement saying, let's do active screening for patients over 65 years of age, maybe with a pulse and an ECG, but really no other comments based on that. At the same time, based on all of this data, in February of this year, the USPSTF came out with their recommendation saying, hey, we don't really find, and this is the same data being interpreted across the Atlantic in 2 different ways, saying that the current evidence is insufficient to assess the benefits and harms of screening for atrial fibrillation. And actually, there's a lot of, the press coverage to this, obviously, suggesting that even with wearables, this guidelines are not really backing AF screening. And the reason for all of this controversy is that a large number of questions remain, right? So questions like, would targeted screening in high-risk groups, is it more effective than screening in a lower risk population like the Apple Watch study, which may not actually impact cardiovascular outcomes? And then more societal question, is screening the most cost-effective way to reduce stroke risk in atrial fibrillation? Because the practice patterns are extremely variable. Large VA studies have shown that even in patients who are diagnosed with atrial fibrillation, who need anticoagulation, do not get anticoagulation. So we're not doing our job right in the first block that we should be doing anyways. So maybe we should focus our attention on that part rather than finding new asymptomatic 10-second AFib, or not 10, but 1 minute AFib in somebody 42 years old. That's one. And finally, the CHATS2 VAS score was never developed in an asymptomatic population. It is extrapolated for its predictive ability for an asymptomatic population group. So does it work as well? I don't think we have the data to suggest that stratification by CHA2DS2-VASc in asymptomatic subclinical atrial fibrillation is the same predictive incremental value as those with symptomatic atrial fibrillation. And finally, despite the stroke stop study, the benefits of anticoagulation therapy on health outcomes in asymptomatic, these incidentally detected older adults with atrial fibrillation is still a matter of debate. And you can see by that differing guidelines that not everybody agrees upon whether that should be part of a strategy or not. And that boils down to the fact that this graph shows various studies where the vertical columns show the percentage of asymptomatic atrial fibrillation. The bars are itself various studies, and the table on the side shows you what the population and the kind of the studies were done. And you can see that you could diagnose very little or a whole lot of atrial fibrillation based on whether you had a population with CHA2DS2-VASc 1 as their mean or a CHA2DS2-VASc 4, and whether you were using continuous monitoring versus a single ECG. So that boils down to the fact that it is a very population dependent paradigm that needs to be applied for this. And therefore, I think I might be coming to the end of my time, if I'm correct. And I'm going to go to the take home messages, which is screening for atrial fibrillation improves AF detection. I don't think there's a lot of argument on that, but the yield varies based on the modality you use and the population you study. And of that, opportunistic screening is mostly agreed upon. I don't think we would find a lot of people who would raise banners against opportunistic screening. But at the same time, systematic screening is controversial. I don't think there is enough data personally to convince me that we should be doing this for everybody, given lack of hard outcomes. And finally, device-detected AF is a headache, right? That is agreed upon. And because of all these nuances that we talk about. And the good thing is there are people working on like the Artesia trial. These are ongoing trials, which uses apixaban for device-detected subclavian, or the NOAA trial, which uses NOACs for atrial high rate episodes that are ongoing that may shed light on what to do with device-detected atrial fibrillation. And I wanted to emphasize this fact. It's unsatisfying, but it is true that it is unclear whether screening improves health outcomes in terms of stroke-related morbidity, mortality for our patients. And that treatment standards, even for established AF, remain suboptimal in terms of compliance, in terms of anticoagulation use, in terms of risk factor modification, and therefore resources may be better invested in treating high-risk patients with symptomatic AFib, the known benefits, rather than focusing on asymptomatic screening. And finally, consumer-driven screening is upon us. Whether we like it or not is a different issue, but we are going to get copies of the AliveCore report sent to our email every day. So with that, I'd like to thank everybody for giving me this opportunity. Thank you.
Aditya, that was a great talk. Open for questions from the audience here. No questions yet from the chat box, but if anybody on the chat has any questions. So let me start by where you ended. So the patients are sending us those tracings from Apple Watch and what have you. Twofold question and brief answers, if you could. How are you managing those atrial fibrillation, and how do you see the load? How are we storing these things? How eventually our nurses and with the nursing shortages are going to be handling the volume once the floodgates open, if screening happens. So what are your thoughts about that?
I don't think I have great answers, but I know that there has to be integration of the wearable information into electronic health record system. That channel is currently patchy communication, but I think ultimately health systems will evolve to integrate patient wearable data as part of their EHR, hopefully protected by a confidential communication line. I think that's where we are headed in the future.
Perfect. A question from Suresh Mulukutla on the line. Can you speak a little bit about the modifiable risk factors other than the traditional ones, diabetes, hypertension? You've done some research on some of these. So again, briefly, Aditya, because we're a little bit running out of time, but.
This is just us being very familiar. This is personal. The internal UPMC data would suggest that in patients with younger patients with atrial fibrillation, smoking, sleep apnea, and obesity are three factors that drive atrial fibrillation in these patients in the absence of traditional risk factors. And I don't think we do enough to either diagnose or treat these appropriately. So I think if our patients didn't smoke, got their sleep apnea treated and lost weight, the one thing that I also think we don't focus on is alcohol consumption, because there's increasing data to suggest that even one drink a day increases your risk of atrial fibrillation. And I think you will find clinical notes not really reflecting the alcohol consumption for our patients. That may be a driver for their AFib.
So again, we're running out of time, but quick question, Dr. Tumalapalli, thank you for your question. He mentions CHADS VAS score of 3, a male person, atrial fibrillation, episode lasting 30 hours, spontaneous conversion. There's no clear question there, but I'm assuming, how do you handle this patient?
I think over 24 hours, a CHADS VASc in a male of 3, I would anticoagulate, and most people would. If it was a female, it would become a little bit kind of on the gray zone, but for a male with 3 of CHADS VASc and 24 hours, that's an easy question. For a female of CHADS VASc of 2 with a 7-hour episode is where I would struggle at answering that question.
Perfect. Yes, Dr. Tumalapalli finished the question and said, asking about anticoagulation. Okay, well, I'll continue, answering some questions, but we're going to need to move on. So thank you, Aditya.
Thank you.